Thank you, Carlos, for the kind introduction. Good evening, good night, night, and maybe night for somebody. And I like to thank Carlos for the kind introduction and Proton group for giving me this honor and opportunity to talk on this Proton lecture series. I'll be talking today retinal vasculitis and update. Mostly I'll be talking my experience only, and most common retinal vasculitis in our country is Eels disease, and I'll be talking our research work on Eels disease predominantly. So retinal vasculitis is inflammation of the retinal vessels, and these retinal vessels are located in the inner plexiform layer. The histologic sections from an eye, you can see that around the retinal vessels, lymphocytic coughing is seen. It is defined by the inflammation of the retinal vessel wall, which could involve the veins. When you involve the veins, it's called periphlebitis. When it involves the arteries or arterioles, is a periarteritis, or capillaries, capillaritis. It's an uncommon sight-threatening retinal vascular inflammatory disorder resulting in a variety of clinical manifestations. It affects around 3% of the uveitis patients. Estimated incidence is between 1 to 2 per 100,000, with the possibility of any retinal vasculitis present in uveitis associated with systemic disease. It could be presenting features of non-infectious, infectious, masquerade, systemic autoimmune disorder, isolated ocular disorder, non-infectious being the most common. And here is the photograph of a normal retinal histology, and you can see the retinal pigment epithelium, and here is the retinal endothelial cell, retinal blood vessels with endothelial cells and pericytes. And what happens is that choroidal dendritic cells, they attach to the endothelium of the blood vessels in the retina, and they attract the lymphocytes and producing an immune-mediated reaction resulting in retinal vasculitis. Causes of retinal vasculitis: infectious, non-infectious is Biswas disease, sarcoidosis, systemic lupus erythematosus, multiple sclerosis, rheumatoid arthritis, seronegative arthritis. Whereas the infectious causes of retinal vasculitis include predominantly Mycobacterium tuberculosis and Treponema pallidum, rarely Borrelia burgdorferi, Bartonella, and Brucella rarely. Retinal vasculitis, when it predominantly involves the veins, that's the periphlebitis, is commonly caused by but not inclusive. This is a Biswas disease, sarcoidosis, tuberculosis, multiple sclerosis, pars planitis, or type of intermediate uveitis, HIV, and birdshot chorioretinopathy. When it involves predominantly the arteries, it's systemic lupus erythematosus, polyarteritis nodosa, acute retinal necrosis, syphilis, IRBAN, that is idiopathic retinal vasculitis, aneurysm neuroretinitis, and idiopathic retinal vasculitis. Systemic evaluation is the main standpoint of diagnosing primary retinal vasculitis. Sometimes we need an extensive diagnostic test to determine the systemic cause of retinal vasculitis. So diagnostic workup of a case of retinal vasculitis involves two parts. One is a basic workup, which should be done in all cases, and laboratory tests tailored according to the suspected etiology. Periphlebitis, that's the inflammation of the veins, is much more common than periarteritis. And in our country, as I mentioned earlier, Eels disease, which was a term which has been used after Henry Eels, is the most common retinal vasculitis in India. A case of arthritis, I will start beginning with that one, as the whitening of the retina is seen. But if you did see the fluorescent angiogram, you can see the patchy arthritis is present. So cause of retinal vasculitis primarily idiopathic, and tubercular etiology in Mycobacterium tuberculosis DNA is associated, which was earlier called Eales disease. It can be associated with uveitis, associated with the collagen disease, associated with the infection, associated with the neurologic disease. Clinical approach of an retinal vasculitis should be, is it a retinal vasculitis alone? Is it ocular alone? Is it associated with a systemic disease like autoimmune or infective? I will talk about Eales disease because this disease we see predominantly in our country, and it was Henry Eales, 1880, British ophthalmologist from Birmingham, described this disease in young adults with recurrent retinal hemorrhage. He believed it to be vasomotor neurosis and not retinal vasculitis. Wordsworth, 5 years later, showed associated signs of retinal inflammation. And these are the two seminal articles which was published by Eales in 1880 and 1882. And you can see that this is the photograph of the article from the journal, Cases of Retinal Hemorrhage Associated with Epistaxis and Constipation. So Eales disease is one of the primary retinal perivascularities, but our recent research showed that it is associated with the Mycobacterium tuberculosis DNA. It's adults seen in the 15 to 40 years, predominantly male, mostly seen in Indian subcontinent. We used to see 1 in 135 ophthalmic patients at Shankar Nethralaya. Now it has reduced a lot. It has got a characteristic natural course which starts with inflammation leading to the ischemia, neovascularization, and fibrovascular proliferation leading to the complications like vitreous hemorrhage, fractional retinal detachment, etc. Our research in Eales disease starts from 1985 onwards. We have published 35 articles in PubMed Index journals. The question we asked at the beginning of our journey is that does Eales disease occur in active systemic tuberculosis? What we did, we went to a tuberculosis research center in Chennai, which was earlier called Madras, and we developed a makeshift eye department and saw 1,005 patients of pulmonary and 108 extrapulmonary TB in a TB hospital. Complete ophthalmic examination was done after dilatation, indirect ophthalmoscopy was done, but no case of Eales disease seen. So we published this in International Ophthalmology, ocular morbidity in patients with active systemic tuberculosis. In fact, ocular tuberculosis was seen only in 14 patients, comprising of 1.39% of the patients with systemic tuberculosis. But when he did the high-resolution computerized tomography of the chest in Eales disease patient, we found around 50% cases, that is 15 out of the 29 cases is found showed pulmonary tuberculosis latent or active. And in X-ray chest, it could detect only 4 out of 29 cases. This may be the reason for missing many of the tuberculosis cases in our previous study. This is a typical tree in bud appearance on the chest CT of a patient of Eales disease. We did several histopathology and immunohistochemistry of the Eales disease specimen, and this is one of the study which we published in Journal of Ophthalmic Inflammation and Infection, immunohistochemical study, histopathological study, and molecular biologic study of an enucleated specimen of a case of Eales disease. This is a patient had Eales disease in the end stage in left eye, while the right eye was enucleated due to the painful blind eye. And this eye showed around the retinal vessels lymphocytic infiltration. We further subclassified immunophenotypically and found that this is a CD8 positive T cells. T suppressor cells were seen, and it was predominantly B cells were absent. We did the PCR from the paraffin section, polymerase chain reaction, and found both the IS6110 and MPB64 genome was present in the specimen. Real-time PCR was also positive for Mycobacterium tuberculosis DNA. We did the epiretinal membrane in Eales disease and other vascular retinopathies, And in comparison to the diabetic retinopathy, we found there are retinal blood vessels are surrounded by lymphocytic infiltration. We did the immunophenotyping of such lymphocytic infiltrate in the epiretinal membrane and subretinal membrane and Eales disease. We found they are predominantly T cells as shown in the below picture, and a few B cells were seen. Epiretinal membrane, we concluded an immune-mediated process with predominantly involvement of the T lymphocytes. We did that intraocular expression of vascular endothelial growth factor, VEGF, and pigment epithelial derived factor in a case of Eales disease. We found that there is a strong expression of VEGF and weak expression of PDF found in patients with the Eales disease vitreous sample. We did the immunoprofiles. We did the genetic profiling of human leukocyte antigens in Eales disease and found immunogenetically it was found to be associated with HLA-B51, CW1, DR1, DR4, and DR52. And interestingly, HLA-B51 was associated with Biswas disease. So we've concluded that the HLA association in Eales disease plays an important role in the immunoregulation and pathogenesis. We did several molecular biologic study of Eales disease specimens, and this was published in British Journal of Ophthalmology. Usage of polymerase chain reaction, detection of mycobacterium tuberculosis complex DNA from the vitreous sample of Eales disease who are undergoing vitrectomy. And in comparison to the control, 5 out of the 12 samples, almost 50%, were positive for the MTV DNA. And none of them were culture positive, indicating that there is a latent mycobacterium tuberculosis DNA, latent mycobacterium tuberculosis MTV DNA was seen in the vitreous fluid in the Eales disease patients and may play an important role in pathogenesis. We did look into the epiretinal membrane in the polymerase chain reactions of the mycobacterium tuberculosis DNA, and we found that 47% of the epiretinal membrane contained mycobacterium tuberculosis genome. This difference was compared with the controls was statistically significant. This is the agarose gel electrophotogram and showing the bands of mycobacterium tuberculosis DNA positive epiretinal membrane. So we concluded that cell-mediated immunological reaction triggered by sequestered mycobacterium tuberculosis antigen causes Eales disease. We did further evidence of association of latent mycobacterium tuberculosis in Eales disease. Prasad Gupta was a vitreoretinal fellow working with us who looked into the Eales disease specimen and patients and found Mantoux test was positive in 73% cases, quantiferon TB gold test 56% cases, HSCT test 34% cases, aqueous PCR 33, and vitreous PCR 22% cases. We could find out an eyeball, which is rare to find in an Eales disease patient, which is enucleated, and paraffin sections from the PCR study showed mycobacterium tuberculosis DNA. And this is a case of a blind eye of an Eales disease patient which has more mycobacterium tuberculosis DNA in the paraffin section. We did some clinical research in Eales disease. Though it presented in the retinal vasculitis, we had a case of which presented with a papillophlebitis initially and later on developed features suggestive of Eales disease. Eales disease occurs between 15 to 40 years, but we have 13 patients at below 16 years, indicating that it's quite it's not uncommon to have pediatric Eales disease, which is the features can be suggestive of which is seen in the adult. Imaging in the Eales disease, we found there is a vasculitis seen in the active state, capillary non-perfusion, which is quite commonly seen, veno-venous shunt as seen in this picture over here in the right-hand side, and we could see the neovascular front is seen in the left-hand side picture. We see the white field fundus fluorescence angiogram could capture the gross capillary non-perfusion at the periphery. And we found that if we do ultra-wide field imaging in the Eales disease, we could find out more amount of hemorrhages, perivascular sheathing, and neovascularization. This is one of the cases where is that perivasculitis is seen in beyond the equator, and is also fluorescent angiogram was consistent with perivasculitis. Where what I am doing now is that SSOCTA in retinal vasculitis shows optical coherence tomography. It doesn't show leak, but it can show elegantly neovascular front and also several vascular changes, like in the macular area, we could see the vascular alterations. And we found by this study that about 63% cases, there are subtle macular changes can be seen in the form of epiretinal membrane, cystoid macular edema, foveal thinning, vitreomacular traction, ellipsoid zone thinning, whereas the epiretinal membrane was the quite common finding in Eales disease patients, which is not seen clinically. Long-term outcome of a large cohort of patients with the Eales disease, we have seen done 500 patients, 898 eyes, follow-up of 15.8 years, 10 to 25 years follow-up was there. And we found bilaterality is ultimately seen in 81% cases. And acute stage, oral steroid is quite a good prognosis. We don't need to recourse to immunosuppressive agents. Laser treatment in proliferative stage, quite a good prognosis. Recurrence not uncommon. 52% patients had greater than 5 recurrences, mostly in the form of neovascularization in 10-year period. We had a rare case of 3 patients who had presumed Eales disease with neurologic involvement, and these patients showed ischemic infarction of the brain and they had generalized seizures. But the clinical finding, fundus finding, was typical of Eales disease. We did a review article, we wrote a review article in Survey of Ophthalmology in 2002, where we reviewed nearly 300 full text articles and found the etiology was varied and controversial. Subsequently, our molecular biologic study over the years has shown that it's seen in the vitreous sample, epiretinal membrane, and in the eyeball specimens, mycobacterium tuberculosis DNA. With this, we concluded that Eales disease should be considered as a tubercular retinal vasculitis based on such current molecular biologic study findings. What we couldn't answer that why females are mostly spared, only that 19% patients are female. Why does the disease occur in 4 stages: inflammation, ischemia, neovascularization, and fibrovascular proliferation? Why the vasculitis exclusively in the eye? What about the etiology of PCR negative cases, where the other mycobacteria could be responsible for the Eales disease? I like to switch gear from the Eales disease, which I have talked about in depth, about our finding studies in Biswas disease, sarcoidosis, and SLE, which are the other common causes of retinal vasculitis. Biswas disease, we don't see that common in our country. It can have the aphthous ulcer, genital ulcer, erythema nodosum, and vitritis, this involvement, optic neuritis, optic nerve involvement, and vasculitis with the retinal exudate. And typical capillary fanning is seen almost exclusively in all cases of the active Biswas disease. We did the 25 patients of Biswas disease, where we studied the clinical profile and management with immunosuppressive and biologic agents, and we found that Biswas disease mainly occurs in the male patients over the year, and that bilateral involvement was seen in 80% cases, and most common involvement is the posterior uveitis in the form of retinal vasculitis. Treatment and visual outcome, we have found that if we treat with the systemic steroid only, the visual prognosis is not that good, whereas the immunosuppressive and recently biologics has improved the visual outcome quite remarkably. Retinal vasculitis and sarcoidosis, it can be seen in certain percentage of the cases. Skip retinal vasculitis in the form of candlework dripping, but which is not that very common in our series. They have found to have hilar lymphadenopathy, bilar hilar lymphadenopathy or chest X-ray, but mostly in CT scan and non-caseating granulomatous inflammation where there is any pulmonary or extrapulmonary involvement was seen. Infection associated with retinal vasculitis could be tuberculosis, cytomegalovirus retinitis, toxoplasmosis, syphilis, and acute retinal necrosis. This is a case of acute retinal necrosis presenting with the or sheathing of the vessels in the superior to the retinal retinitis lesion. And this is a toxoplasma lesion with chyleriasis arterialis involving the arterioles predominantly. In active toxoplasmic retinochoroiditis, we have seen retinal vasculitis occurs in cases of serpiginous choroiditis in few cases, and these are the cases are mostly having tubercular etiology. Acute retinal necrosis can have retinal vasculitis as a component of that presentation. We had a histopathologic and molecular biologic study of an eyeball of a case of acute retinal necrosis, and which you could found that the occlusion of the retinal vessels in the due to the fibrosis following inflammation, as well as viral inclusion bodies could be seen. And molecular biologic studies showed herpes virus DNA. Ocular syphilis can also, retinal vasculitis can rarely occur, and we could see along with the vitritis, retinal vasculitis as seen in the yellow arrow. And we had one case of retinal vasculitis, 55-year-old female, RPR negative, and TPH was positive in 1:120, 1:1280 dilution. And this patient had got beaded appearance of retinal vasculitis due to the syphilis. And this has been reported by others also, beaded pulse in retinal appearance in syphilitic chorioretinitis. Collagen diseases, top on the list is systemic lupus erythematosus, which can produce occlusive retinal vasculitis, granulomatous polyangiitis, polyarteritis nodosa. Other collagen diseases can also produce retinal vasculitis. We published our series of systemic lupus erythematosus associated uveitis in India, and of which we found retinal vasculitis is seen around 70% of the cases. Anti-DS DNA antibody was present for positive in 100% cases. Vision improved with the immunosuppressive and steroid in 23% cases, stable in 77% cases, worsened in 7.6% cases. Active vasculitis was seen in 27% cases, healed vasculitis 23% cases. And here is a case of systemic lupus erythematosus. You can see the cortical exudates along with the retinal vasculitis with hemorrhage predominantly involving the posterior pole. And this is the immunofluorescence study showing the speckled hyperfluorescence, and positive anti-DS DNA was seen in this case. Retinal vasculitis can be occur due to the rheumatoid arthritis. We had a case of seronegative rheumatoid arthritis with retinal vasculitis with hemorrhage, and this patient responded elegantly with anti-TNF alpha inhibitor, and however, the patient had reactivation of past tuberculosis. Idiopathic retinal vasculitis, aneurysm, and neuroretinitis is a typical ocular vasculitis, and here you can see that vascular alteration of the retinal vessels with the beaded appearance of the aneurysms at the optic nerve end along the superior arcade with the surrounding exudates. And this is the other eye. And these patients had occlusive vasculitis and can be seen as very exclusive capillary non-perfusion, gross capillary non-perfusion is seen in this case. And this can be elegantly documented by SSOCTA, where you can see that beaded appearance of the looping of the retinal arterioles. So it's a rare clinical entity with unknown etiology, typically affects young, healthy individuals as male preponderance. Inflammation of the retinal vessels is seen and association with ocular inflammation. Phlebitis is more common than arthritis. IRWAN can lead to the severe vision-threatening complication. SSOCTA can be beneficial in the evaluation of a case of evaluation. I'll be showing a few cases of frosted branchitis, a very peculiar type of retinal vasculitis. We reported in the Retina Journal bilateral frosted branchitis in an 8-year-old girl, Indian girl, with rubella virus infection. And subsequently, we also have another patient of frosted branchitis bilateral in a 5-year-old boy due to the Epstein-Barr virus infection. This boy had sudden loss of vision, both eyes for 11 days, fever with maculopapular rash over the thigh and buttock. Vision was grossly decreased, 3/60 in both eyes, and had got extensive frosted branchitis. And this patient was treated, anti-Epstein-Barr virus, IgG was 420 international unit. Anti-rubella virus was also elevated, but IVLP as well as followed by the oral prednisolone and tablet valacyclovir was given. This responded elegantly with the vision coming back to the normal 6.5 N6 in the right eye and 6.6 N6 in the left eye. Anti-Epstein-Barr virus titer became 225, half of the one following treatment. We had a unilateral frosted branchitis in a patient with abdominal tuberculosis. And this is a 17-year-old girl, biopsy-proven abdominal tuberculosis with having retinal hemorrhages with frosted branchitis. And this patient responded with the treatment with ATT and steroid. There is a complete resolution of angiitis with the treatment. The frosted branchitis has been reported in cytomegalovirus retinitis. We have got an elegant picture of a case of frosted branchitis due to the cytomegalovirus retinitis in an HIV-positive patient which responded with the anti-CMV therapy. We have reported a case of frosted branchitis with granuloma formations in a case of sympathetic ophthalmia. We feel frosted branchitis is a sign only and can occur in various infective and even non-infective autoimmune diseases. Retinal vasculitis can occur with neurologic disease like multiple sclerosis. We had a patient of recurrent anterior uveitis and healed retinal vasculitis associated with the multiple sclerosis, and there is a hyperintense lesion in the posterior limb of internal capsule and corner radiator was seen, and you can see the retinal vasculitis in the mid-periphery. Can systemic or ocular malignancy present with retinal vasculitis? This is a patient of primary vitreoretinal lymphoma presenting with retinal vasculitis, and optical coherence tomography showed sub-RP infiltrate, and the vitreous biopsy, MYD88 mutation was positive for L265 mutation, and the vitreous biopsy showed atypical lymphoid cells, which is found to be B cell positive. And this was the atypical lymphoid cells from the vitrectomy specimen. Immunohistochemistry showed predominantly B cells, CD20 was positive. We had a case of chronic myeloid leukemia, which presented with vitritis as well as retinal vasculitis. Extensive retinal vasculitis was seen, and this patient was having the serous retinal detachment. So what are the investigations which you need to do in a case of retinal vasculitis? Is it worthwhile to do investigation? And when and what? There are several laboratory investigations. The list is very long for a case of retinal vasculitis. What we propose is a tailored and focused laboratory investigations, and you may not get all the investigations done in one go. You may need to go for stepwise approach and can be often non-contributory. So we found in Hill's disease patients, investigations as Mantoux, quantiferon, HRCT chest is quite helpful, and seen tubercular etiology in clinically suspected Hill's disease is over 50% of the cases. Management of the retinal vasculitis is the last phase of my talk. Infective cases, we need to treat the infection first, which may need to combine with the oral corticosteroids. Primary or associated with autoimmune disease, systemic steroid is a primary treatment, but if not responding, immunosuppressive agents can be added. And this is a case of infective vasculitis. This is a case of tubercular retinal vasculitis. MANTU was positive, Q2B gold positive, HSCT chest was positive for tuberculosis. Signs were seen, and you can see the thick cupping of the vessels was seen, which is very typical for tubercular retinal vasculitis. And this patient responded elegantly with antitubercular treatment and steroid. Inflammatory stage in management of Eels disease, treating with the corticosteroids and antitubercular treatment, which you have given. Antitubercular treatment is given for preventing the recurrence of retinal vasculitis, neovascularization in laser photocoagulation, and vitreous hemorrhage, tractional retinal detachment, vitrectomy with or without endolaser. In case of Biswas disease, we found immunosuppressive agents is beneficial, and this is a case which responded with cyclosporine. But nowadays we are using biologics in retinal vasculitis, and our series of 2020, 18 cases of patients of uveitis and scleritis, and few of them are Biswas disease, where we used injection adalimumab and showed good response to the therapy. In conclusion, Eels disease is a very common retinal vasculitis in our country and mostly predominant retinal vasculitis. And we concluded by our study that is a T-cell mediated immunologic response to mycobacterial TB DNA in a genetically predisposed patient. Ultra-wide field imaging is beneficial, is required to document the vascular changes in Eels disease, particularly the neovascularization. Retinal vasculitis can be associated with the various ocular and systemic diseases. Prostate bunch angiitis is a sign only and not a separate disease. Management depends on the etiology of the retinal vasculitis. If it is infectious, you need to treat anti-infective agents, and systemic steroid works in majority of the cases. Immunosuppressive and or biologicals are beneficial in Biswas disease and SLE. So I like to conclude with a quotation from T.H. Huxley: "The known is finite, the unknown is infinite. Intellectually, we stand on an islet in the midst of the ocean of inexplicability. Our business in every generation is to reclaim a little more land." That's what we are trying to do in case of Eels disease, which is common in our country with the research for last 40 years. And this is in the continuation of the belief and motto of our late founder, Dr. S.S. Badrinath, whom we are trying to follow the life and legacy of this great person. Thank you very much for patient hearing.
Thank you so much, Dr. Biswas, for your outstanding talk. I don't know if someone here have any question to make to you.
Can I make some comments?
Please.
Yes, bro.
Jyoti, thank you. Amazing. You really are an incredible source of knowledge, and we are privileged to have you teaching us in the way you do. So thank you for that. It's just really incredible your work in eels. Ever since I started looking at eels disease and this high prevalence in India and the TB, in my mind there was always a link between TB and eels, but you cracked it and you demonstrated it very, very elegantly. The link exists. The one thing to mention about the PCR that you're questioning, you couldn't explain why what happens with the negative PCR cases. And I can offer you an option. Maybe the sensitivity of the PCR is not good enough, and it's not that they are negative. Is that the PCR test failed to find them, and I think metagenomics today probably will become the way to go with when you're looking for infectious diseases in the eye, because it will identify the pathogen when the PCR fails you. We had a beautiful case here, which for you may be not beautiful because you may have seen so many more, but we had a a young English lady who went to South America and developed leptospirosis in South America 5 years ago. And since then, she's been having recurrent anterior uveitis. And essentially, for 5 years, nobody knew what she had. Treated, getting better, getting worse, etc. Until we did a PCR negative all the time she tested, did metagenomics, we found the leptospira in her eye. So I wasn't aware leptospirosis could be 5 years actively replicating and causing problems in an eye. So for me, it was a big surprise. But I think metagenomics will become, when available, more widely. At the moment, it's very limited access. But I think it will potentially resolve a lot of these cases when we are not sure. In terms of other comments, other things you presented, in our experience here, the lupus cases, I don't normally see uveitis in them. I see more vasculopathy. I see more vascular occlusion. And when I see these large vessels occluded and bleeding, it's usually antiphospholipid positive as well. So they carry another risk factor for vascular occlusion. So I very rarely see real uveitis in lupus. I see more the occlusive vascular disease rather than that. And you showed some beautiful examples there of Behçet's and all that. The one thing that I like to just mention as our experience here, sometimes Crohn's disease can look so much like Behçet's disease in terms of the way it manifests in the eye, and systemically some patients have manifestations can be overlapping as well. I think another disease to keep in mind as a retinal vasculitis is Crohn's disease. It's very, very similar in many ways even neuro disease can happen in Crohn's. So it's a really interesting disease to think about. But I think I'm here just being very happy that I had the time to connect and listen to you, because it always enriches my understanding of things, and I really appreciate your talks. I remember sitting in your room there for an afternoon looking at all your slides with you years ago, and my memory is there all the time, remembering your words. So Jyoti, thank you so much for your wisdom and for sharing with us.
Thank you very much, Carlos.
Thank you so much, Prof.
Can I ask one question?
Yes, sure.
The most important pathology, if you see, and the anatomical configuration of the retinal vessels. Retinal vessel lack internal elastic lamina. Now, is there any role of any vasculitis? Because this the rest of the body, the muscular arteries and muscular everywhere, we have a internal elastic lamina, and it is lacking in the retinal blood vessels. Now, if we target the biomarkers for internal elastic lamina, if we know them, then if we enhance these things in the retinal disease, whether this can be some of the, because you see the nitrous oxide synthesis in ill disease or other oxidative factor affects in the migration of the cells, okay? Whether this is because of the main anatomical defect of the absence of internal elastic lamina in the blood vessel, which makes differ from retinal vasculitis from the other vasculitis.
I appreciate your point, and this is a good thought. I appreciate.
Thank you so much for that question, Doctor.
Any comments?
I have a comment and a question, Dr. Biswas. Thank you so much. Your work is impressive, and thank you for your talk. We always learn from you. I have a comment and a question regarding the specificity and sensitivity of PCR in ocular tuberculosis and Epstein-Barr virus. What do you think? What are the rates of false positives and false negatives? Because we know that it can be negative, but still be the disease. But do you think there are false positives due to the barrier damage? So, however, what should we do about false positives due to damage to the blood-retinal barrier?
Yeah, as the PCR is a very sensitive test, there is always a chance of false positivity. We need to correlate with the clinical findings. And sometimes sarcoidosis can mimic retinal, like tubercular retinal vasculitis. So we need to see the other findings like, hilar lymphadenopathy, etc. And see that whether it's correlates to the clinical finding. Though we have got the PCR, we look into that clinical finding, clinical phenotype always.
Yeah. Thank you.
Alejandro, just one comment
Yeah.
on what you said.
Okay,
The
Carlos.
one infection that very much worrying you about false positive is Epstein-Barr, because
Mhm.
Epstein-Barr can travel inside of the cells, the white cells. So if
Yeah.
you have, easily you can find Epstein-Barr in the eye, and it doesn't mean it is really causing the problem. So that is one of the sources of confusion many times, because it's not necessarily the reason for what you see. That definitely one. I think that there are many other situations when you will find something, and as Jyoti was saying, you have to correlate with the clinical finding and make sure it makes sense, because sometimes it doesn't make sense. But I think Epstein-Barr is the one that most of the times I worry about it, because I've seen many cases described as acute retinal necrosis induced by Epstein-Barr. And I really don't know if it is the cause. I think it could be just something that was found in the eye because of the white cells flooding into the eye and then carrying the Epstein-Barr at the same time. So I think it's always a concern. You're absolutely right to ask that question.
Okay, thank you, Carlos.
Any other questions or comments?
Actually, I have three questions, and taking advantage that we have here Prof. Pavesio and Prof. Alejandra, maybe would be very interesting, the discussion on this. And my first question is related to ruling out antibodies, anti-nuclear, ANAs, because sometimes we see that in several practice, some physicians are asking these types of antibodies when they faced retinal vasculitis in the first visit. But do you consider that is a good approach to this patient, or maybe we must delay to ask these type of antibodies in these patients with retinal vasculitis?
I look into the clinical picture of the patient, and if the patient is a female, young girl, and all, then anti-double stranded DNA I order. But we have got a East disease type of patients who is a MANTU quantiferon strongly positive, and there that ANA is not very helpful, because ANA can be positive in the tuberculosis patients also. So we do the anti-double stranded DNA in such cases.
I very rarely order ANAs. I think the most frequent use for us is JIA when you're trying to identify patients at high risk of developing uveitis. I think in patients with occlusive vasculitis, as we discovered about vasculopathy suggestive of lupus, then of course finding that is useful to correlate. And sometimes in scleritis, it might be of some use, but I don't normally use it for my screening of retinal vasculitis. If it's an inflamed eye, I find it less useful. So I don't tend to do it very often.
Carlos,
Yes,
your
yeah,
mic
thank you
is
so
off.
much. Yeah, oh, here there is a new question. How useful is serology for leptospirosis? Is asking someone here in the chat.
We in our Chennai or in northern part of the India, we did not find leptospirosis as a common cause of retinal vasculitis. But in some belt of Madurai area, Dr. Ratnam, Professor Ratnam et al. Has found that leptospirosis is an important cause of retinal vasculitis. And that's in the particular seasonal area after the flooding of that one, and then there is a kind of a waterborne disease. So I don't routinely do the leptospira. In certain pockets, leptospira is predominant.
Yeah, for me here is a very, very rare thing to think about. I tell even this patient I mentioned before, I never thought leptospirosis at all. It was just a very, surprising finding from the metagenomics outcome, and for me, it was just a big surprise. So we don't see it very much. But yes, we know very well that leptospirosis can cause systemic disease, very widespread disease, myositis, kidney disease. A lot of things happen at the time of the acute disease. And it wouldn't surprise me to see involvement of the eyes during that time. And I think, as Jyoti was saying, in some parts of India, probably because of the exposure during the times of flooding, that's when you're likely to potentially see that. But here, for me in London, it's something I don't even think about it.
Thank you so much, doctors. My second question is, when do you define idiopathic retinal vasculitis? Because also we see in practice of some physicians that some have the concept that they have to ask all the possible clinical tests, but there are other ones that are more focused on the clinical symptoms and signs of the eye of these patients. So they just rule out the most probable etiologies, but there are no like a consensus or a clear definition at this point when is a real idiopathic retinal vasculitis, or not real, but when you consider is idiopathic retinal vasculitis, and when is not a idiopathic retinal vasculitis.
So idiopathic retinal vasculitis is mostly a diagnosis of exclusion. When you rule out tubercular retinal vasculitis, sarcoidosis, Behçet's, and systemic lupus erythematosus, and then the features doesn't really fit with this kind of picture, then we call as a idiopathic retinal vasculitis. But you need to work up for the rule out other causes of retinal vasculitis before calling it as idiopathic retinal vasculitis.
I think idiopathic is a measure of our ignorance. So I think it is when we are unable to find an explanation, we say idiopathic. And as our knowledge expands and our ability to find pathogens expands, probably the number of idiopathic cases will shrink. But we all have patients. We look at everything. We can't find an explanation. We investigate. We turn the patients inside out. There's nothing to explain. Those are the patients you end up saying you have this condition called idiopathic. The patients think it's beautiful. No, idiopathic vasculitis. It looks wonderful, but it just reflects our ignorance and not knowing what's going on. But I think the importance here, according to what you heard from Jyoti just now, as long as you have excluded an important, serious underlying reason, infectious especially, the neoplastic, then it gives you the freedom to say, okay, I'm not worried about immunosuppressing this patient. I'm not worried about my intervention causing more harm. So if you're unable to find something, the most important thing is exclude infection, exclude a potential masquerade, and then you are free to unleash your weapons in trying to control the inflammation and the vascular damage. That's how I see it in a practical way.
Thank you so much for that comments, doctors. And I just raised one question more, additional to the three ones, but my last question that was previously thinking during the talk was when you stop treatment, because sometimes the leakage doesn't goes from the area, and even we make FFA, we are going to still seeing some like some leakage, or even is reduced or have changed. There are leakage, and we don't know when is like completely quiet the retinal vasculitis, or when we have to continue the treatment in these patients.
The capillary farming, which is often seen in Behçet's disease or retinal or intermediate uveitis particularly, that doesn't really go off with the treatment. If you adequately treat for 6 to 8 weeks, and after that you can stop the treatment, and you don't really go for that capillary farming to go off in retinal vasculitis?
I think the question is always a tricky question for us, is when to stop treatment. I think if you have an infectious origin, then you treat the infection, and most of the times you can control the disease long term, and you may be able to stop your treatment. If it's not infectious, it's immune mediated, then it's harder. Which biomarkers are telling you it's safe to stop? And sometimes it's very straightforward. You see no inflammation for a long time, and you feel comfortable to try to stop. Other times, even if after some time they still reactivate when you stop everything. So it's very difficult in the absence of a proper biomarkers of disease activity. But I think one thing to keep in mind, sometimes if you have ischemic changes, especially in occlusive vasculitis, you find leakage happening in the area of the ischemia or macular edema, which could be secondary only to the ischemia itself. So lasering those areas, getting rid of VEGF in the eye, is really important way of making sure you're not over-treating when the reason for the problem is actually no longer inflammatory, is just the ischemia and the VEGF production. So I think it's not an easy question to answer. There's several elements to it, but I think if you rationalize, you eventually find a way of trying to come off medication.
Thank you. Thank you so much for that response. And my last question is to Dr. Pavesio. You are using 16S metagenomics or shotgun metagenomics in these new patients that you are looking for the ocular samples?
Yeah, I'm not an expert in metagenomics. It's done at Great Ormond Street Hospital. It's not even done here in our institution. It's the only place where we can do it. And it just looks across to everything. So essentially, the sample will allow you to look for viruses, for fungus, for bacteria, for everything. So it's not limited to bacterial pun, fungal. It looks at everything. It's an incredible technology because in PCR, you have to know what you're looking for because you have to have a primer that can react. In metagenomics, you don't know what you're looking for, and it will find it for you. So I think it is at the moment, it still costs £1,000 a sample. So it's a very expensive test to run at the moment. It's very, very difficult. But I think, as always, these technologies start being very expensive, then the costs come down, and on more places will be able to do it. So we are just doing a series of 20 patients now. I found a toxo case that we couldn't find toxo in PCR, and metagenomics found the toxo there, a very unusual case. But we're hoping that our results will kind of give us a sample, a flavor of the benefits of this approach. So I think I'm looking forward to seeing more of this.
Thank you so much, Prof. I have reviews several, there are 2 or 3 papers right now. I think the group of Proctor is using also metagenomics, but also there is a group in China that have made something similar with a lot of samples. But I think in that paper, the issue was that they just use 16S that just cover like bacteria. But thank you so much for giving up this new technology, and will be very useful, and hope the future looks much better for these patients. I don't know if in the auditorium there are other people that have any question to Dr. Biswas.
I just need to say one thing, Jyoti. I'll have to leave the session. I have another meeting to attend now, but thank you again. Amazing privilege I had to listen to you, and I'm looking forward to seeing you coming to Brazil, Jyoti.
Yes.
Wonderful. We'll see you there. Okay.
Yeah, see
All
you
the
there.
very best.
Bye.
Thank you. Bye. Thank you,
Bye.
guys. Thank you
Thank
very
you,
much.
Thank you.
Bye bye. Bye bye.
Okay, I think maybe there are no more questions. So we have to first thank you so much, Prof. Biswas, for your outstanding talk. It was very clear, and it gave us light to see in a different way many things, and open our eyes to this very important part of ill disease that is the tuberculosis, and all your discoveries in this disease. Thank you so much for everything that you have made research, Prof. And thank you so much for your outstanding talk. So right now I'm going to stop recording, and hope I can see you, all of you, in the next